Hello, my name is Dr. Sundar with OrthoVirginia. Thank you for joining our Facebook Live this afternoon. And I think we are just about ready to get started. So the goal of today's talk is just to talk about what is interventional pain management and what we do as interventional pain physicians, more specifically in this practice as well. So a little bit about me, we'll just kind of go who I am, what it is that I do, what do we treat, and just kind of go over the different types of procedures we do. And I'll make sure to leave plenty of time for some questions and answers at the end. So who am I? So like I said, I'm Dr. Sundar. I did a combined 7-year undergraduate medical degree, 3 years undergrad, 4 years medical school. My primary board certification is in anesthesiology, and then I continued to do an extra year in interventional pain medicine, all with the Mount Sinai Health System in New York City. And I've been lucky enough to practice in both anesthesiology and interventional pain physician since finishing training. So I feel like that allows me to, have a little different perspective on certain things. And so what is interventional pain management? So it's a very good question because a lot of people, even within medicine, may not know. Pretty much it's the use of minimally invasive procedures to target specific areas of the body. Any pain or, painful site. It could be the neck, the back, shoulders, the major joints in their body, and targeting specific nerves in the body as well. But sometimes, even despite the name interventional, sometimes procedures just aren't the key. Pain physician, we often think, it's only for chronic pain patients. That's not necessarily the case. It could be an acute issue, something that's lasted less than 3 months, something that's lasted longer than 3 months, as in the definition of chronic. Particularly in orthopedic practice, sometimes it's for pain that's existent before surgery, and of course for patients that continue to have pain after surgery as well. So then what do we treat? I think it's safe to say majority of interventional pain physicians, our major scope is the spine, predominantly the cervical spine or the neck or the lumbar spine or the low back. And causes of pain here could be arthritis, disc herniations, the muscles themselves, the joints due to arthritis such as the shoulders, hips, and knees. And sometimes there's different nerves in our body that get aggravated, so we could target nerve-related pain as well. And so we're just going to go a little bit into detail about the different things. I'll try to, not go into too much detail so we have time for questions. So jumping into the cervical spine or the neck, most common causes of pain that we treat are arthritis. Facet hypertrophy is the medical terminology for this. A facet is the name of the joints we have in the spine. And what can cause this type of arthritis in the neck? Just normal aging process, wear and tear, trauma. And this type of pain tends to be localized to the neck. It doesn't tend to be a shooting type of pain that you may experience with the nerves. And we could treat this with NSAIDs or non-steroidal anti-inflammatory drugs. Some over-the-counter examples include ibuprofen or Aleve, but there are other prescription variants as well, physical therapy and injections. And injection options, trigger points, that's where we inject medication into the muscle itself to help with some muscle stiffness. The medial branch is the name of a very specific nerve that we target to help treat pain due to arthritis of the spine. And then if successful, sometimes we could even apply heat to that nerve. Applying heat, what we call that is called the radiofrequency ablation. Still a targeted approach and very similar to blocking the nerve, but there are some special nuances that go into that as well. And this is just an illustration showing what that exactly looks like, obviously in a more three-dimensional setting. We're not going into the spine itself, but there's medication that's kind of injected along the bony cage of the spine. And sometimes you have nerve impingement in the neck, so it's not always just arthritis. So this can cause pain to travel into the shoulders, the arms, down to the hands and the fingers as well. Sometimes this is due to a disc, a gelatinous structure that sits in between our bones. It can herniate or go backwards, pinching the nerves. Spinal stenosis, which is narrowing of our canal, could happen due to age or due to trauma and or arthritis. And as you can see here, kind of very similar, we could use medications, physical therapy, and a different type of injection here called an epidural steroid injection. And this is another illustration demonstrating what the epidural steroid injection is. So the epidural is a very thin layer within our spinal cord where we target so that we can inject medication, usually steroid and saline, to help cut the inflammation down in the canal itself with the hope of relieving pressure on those nerves and that disc. And by doing that, if you relieve the pressure, relieve the swelling, and hopefully relieve the pain. And now we jump into the low back. And I think you'll find here there's a lot of similarities to the cervical spine or the neck. So same thing, arthritis can be a cause of the pain, wear and tear, trauma. This kind of pain, again, can be localized to the low back, to the buttock region. It can sometimes go sideways into the legs, but it often may not be like in a shooting style pain. Treatments, some medications, physical therapy, and injections. And as you see here, it looks very similar to treating arthritis of the neck because it is similar. Trigger point injections, injecting into the muscle directly. Those medial branch blocks where we target specific nerves along the bony cage that supplies the joints of their spine, aka the facets. And if that works, same thing that like in the cervical spine, we could even apply heat to them. And I have this illustration in here just to show that the difference is purely anatomical, but the goal is the same. Get along the bony cage of the spine to target these specific nerves. The target area being that blue area that you see in the illustration here. And again, nerve impingement can also cause pain in the low back. And depending on where the nerve is being pinched, we may experience symptoms differently. It may go to the hips, the buttock, the thighs, and then lower down herniations can even cause pain to go below the knee to the calf and the foot. And similar process, we could use medications, therapy, and injections, period. And I have this illustration here to show what a disc herniation may look like. So the top of the slide shows the back of the spine, and the bottom of the slide shows the front of the spine. So we have this disc that sits in between our bone, and there's like a jelly-like structure here, what's in pink. And sometimes that can, unfortunately, be pushed backwards or herniate. And we see that patch of red on the right side of the image here, that's being irritated, and that's what's causing the nerve pain to go down into the leg. And other causes of pain, don't want to go too much into this for this more general talk, but sacroiliitis, that's where the bottom of our spine or the sacrum meets our pelvis. There are a couple of joints there, sometimes that could be irritated. Unfortunately, fractures, and of course, it could also be our hips as well. And so this image indicates that sacroiliac or an injection for sacroiliitis. That blue you see on the left of the image, that's outlining the joint to which we inject medication into. I don't want to go too much into detail. We could easily have a huge talk just on this alone, but a kyphoplasty is a procedure potentially done for fractures of the spine, where we could see here on the left slide, there's a wedge-like deformity where the bone is kind of squished. So if deemed appropriate, we could put a hollow tube into the bone, inflate a balloon, and then fill that cavity up with cement to help stabilize the fracture. I just want to introduce this as a potential treatment option, but again, this alone is like a huge discussion to be had. And as I mentioned with the low back, sometimes you may have pain due to the hips itself. So I want to jump into joint pain as something we could target in interventional pain medicine. This is often due to arthritis, at least in our field. I'm sure from the surgical standpoint, there may be other reasons for joint pain. But injections are an option when maybe surgery is not yet indicated, or if a patient is not yet ready for surgery as well. And the best thing in treating all these painful conditions is combination of therapy, physical therapy, medication, and injections. And the most common thing in most pain practices is injecting steroid with a mixture of numbing agent and saline. Sometimes joint pain may be nerve-related, which we can tease out with certain diagnostic procedures such as nerve conduction studies. But similar process, we could do nerve blocks, similar to a steroid injection, except the area we're targeting is a bit different. Physical therapy, medications, and to make things a little bit more confusing for us, because sometimes it's not always so clear-cut, sometimes joint pain can be coming from the back. So someone's knee could be coming from the back, someone's elbow pain or shoulder pain can be coming from the neck. And then ultimately, it's great that we have, a broad sense of what we do. We kind of find an area that hurts and we inject it and see if it works in conjunction with medicine and physical therapy. But what role do we play? I would say the biggest role we play is, we're just another member of the care team. We need to work with the primary care physician. Are there medication interactions with something that they're already taking? Work with the surgeon, which is very important. Our practice here at OrthoVirginia, physical therapists. A lot of our patients also see chiropractors on the outside. So a closed loop of communication is very important because, like I said, sometimes injections aren't the answer and they're not going to fix the problem. Majority of the procedures that we do, it uses some sort of image guidance that allows us to be more specific and target the structures in a precise way. That adds not only to the safety of the procedure itself, but also allows us to really hone in on where we need to go. So we use either X-ray guidance or ultrasound guidance. And while some procedures can be done by a blind, done by feel, really depends on the procedure and what is best for the patient. And so just to go over everything, this is just a brief overview of procedures that we do. Trigger point injections, which are injections into the muscles themselves, joint injections. We could target specific nerves. We could do what's called an epidural steroid injection for those nerve-related pains coming from the spine. Medial branch block for those arthritic type of pains coming from the spine. Kyphoplasty, which is again that procedure to help treat fractures of the spine. And although we didn't go too much into this, spinal cord stimulation is another more advanced technique to help patients in pain when you've done all sorts of other things, injections, medication, therapy. Some people have even had surgery, and it's more of another tool in our toolbox to kind of help reduce pain. And I didn't want to go too much into this because it's very easy for us to have an hour-long chat on spinal cord stimulation alone. And we have, multiple offices all throughout the state of Virginia. You could definitely go online or OrthoVirginia.com/appointments. And you could find my page at OrthoVirginia.com/physicians. I particularly work in the Northern Virginia region. But I do have a couple of colleagues in the North as well, both Dr. Danielle Cherrick and Dr. Peter Ye, also in the North. But we have, pain physicians throughout the entire state working collaboratively with our surgeons and therapists. And I think that's a good time for some questions.
Thank you so much, Dr. Sundar. So our first question is, how long does pain relief from an injection last?
That's a good question. Unfortunately, that is a very hard question to answer because everyone is different. I often tell patients, let's focus less on the pain score out of 10 and the percentage and focus more on quality of life and functional status. If a patient says they could barely walk before, now they could walk with much, less pain, I consider that a win. And how long that lasts, everyone is different. For some people, unfortunately, it may not work super long, maybe just weeks to months. Then we've had patients, they say that lasts them months to years. Every patient is variable. Medications work differently in every patient. There's it's not just the injection itself, other factors, coexisting conditions, weather can play a role, stress can play a role, so many things, but unfortunately, it's a difficult question to answer. Ideally, I wish I could say it works for many, many, many months, but unfortunately, that's not always the case.
You brought up, pain in hips and so on. Mm-hmm. Is there anything you can do for joint pain in fingers?
Depends on the finger. A lot of our offices do have hand surgeons, so it depends what the cause of the pain is. Is it nerve-related pain where maybe an injection or potential surgery can work? Is it just, is it a more inflammatory type of pain, arthritic-related pain? So fingers themselves may be difficult to treat. We have injected into the thumb itself in the past, at the base of the thumb, but it really depends on what the cause is. I myself haven't done a lot of hand cases, given that we have hand surgeons in our practice, but there are options, correct.
Are there any age restrictions for any of these procedures, either upper limits or lower limits?
Lower limits, given a lot of what we treat is wear and tear, I just tend not to see a lot of pediatric patients. So lower limits, I probably wouldn't offer, someone in their early teens, some of these injections, just because it's a lot to handle. Same thing if you're much older, really depends on the patient. We've had 91-year-olds who are still playing pickleball and very active. And, for them, they want to do anything they can to enjoy life as long as they can. So it's really patient dependent, but there's no hard limit, I should say, on the age exactly.
Are these treatments covered by most insurance?
Most commercial insurance and Medicare, these things are covered. Now, naturally, a lot of things are constantly changing, if not daily or quarterly. And it's a new year, so a lot of things have reset. So we kind of have to see what is and isn't covered. But luckily to say, the bread and butter things of what we do, the most common things we do tend to be covered by most insurance companies, correct.
Are you able to treat back pain from scoliosis?
Depends on the degree of the scoliosis. So we could definitely try. There are different options available. Now, is the scoliosis what we call degenerative from normal wear and tear as we get older? Or is this person with scoliosis very young where maybe surgery can fix the scoliosis? So from an interventional pain standpoint, there are treatment options, but I always tell patients in that particular case, injections plus therapy, and then definitely at least a surgical consultation to see if surgery is an option.
What do you recommend for muscle or tendon pain after a joint replacement?
So that's, unfortunately, there may not be a whole lot we could do right away with that because there's just so much swelling you have immediately after a joint replacement. The surgeon will often give pain medications to at least help with the initial response. Sometimes I have done the different nerve blocks to help with that muscular type of pain or joint nerve-related tendon pain. For some patients who are just having a little bit harder time with the range of motion exercises post-operatively. But so I would say, just over-the-counter medications with the possible nerve-related injection. We don't want to use any topical agents in the area because you have a pretty fresh incision there.
Do interventional pain management specialists treat complex regional pain syndrome?
Most of us 100% do. I certainly do, and I know my colleagues up here in the north definitely do. It's in the name. It's complex. For those that are listening that don't know what that is, that stands for CRPS. It's a condition where the body has decided it's going to heal in a funky way, for a lack of better ways of putting it. And patients may have intractable pain in the arms or the legs or the hands or the feet. But we do treat it, again, different injection options in conjunction with the therapist, different medications. It's not always an easy thing to treat, but if caught early and treated early, we could definitely help reverse some of the symptoms. But yes, 100%, most interventional pain physicians, including myself, do treat CRPS.
Epidural steroid injections and limits to them. So are there a certain amount that you are allowed to get? And if you've had one successful one in your spine, would you be able to have a second one?
So great question. It's a common question I get. How often can we do this? It depends on the patient, and unfortunately, the insurance as well. I always tell patients, rough guideline is 3 to 4 a year. Insurance things aside, we also don't want to just constantly keep injecting steroids into the body every 2 weeks or 2 months, because too much steroid, is also a bad thing for the body. It can cause the muscles to weaken, the bones to weaken. That's why it's very important to space them out as much as we can. So the easy answer to say is 3 to 4 a year. I try to tell my patients the further out we could spread them out, the better. Now, obviously, if someone has what we call an acute herniation where a disc is bulging and pinching on a nerve, sometimes we'll do them a little sooner just to kind of help the healing process along much sooner if surgery necessarily isn't quite indicated just yet. If you had a successful injection, if enough time has passed and the symptoms return, you 100% are eligible for a repeat injection. What I do tell patients quite often is a successful injection the first time doesn't always mean it will be as successful the second time, and vice versa. If it wasn't as successful the first time, we may have a grand slam the second go around, because injections may be absorbed differently at different times. We could do the same procedure 10 times on the same patient and may get 10 different results.
All right. Thank you so much, Dr. Sundar. That is all the time we have for today. If you would like to close.
Sure. Yeah. So thank you so much for joining our Facebook Live today. Hopefully it was a good brief overview of what interventional pain physicians do in today's medical landscape. And we hope, feel free to reach out to us, make an appointment with any of our physicians in the state, and hope to see you soon. Thank you.